Okay, so you've sent us some really detailed material on hypercoagulability and thrombosis.
Yeah, it can look pretty dense.
Definitely. It can feel a bit like trying to read a medical dictionary cover to cover. So for this deep dive, our goal is really to pull out the key stuff, the essential understanding of what's happening when the body tends to form blood clots, without drowning in all the technical terms.
Exactly. And at its heart, hypercoagulability is, well, it's about an imbalance. Think of your blood having signals that say clot now, the procoagulants, and signals that say stop clotting, the anticoagulants.
Right.
Hypercoagulability happens when those go signals are just too loud or the stop signals aren't strong enough. And that an imbalance, that's what can lead to thrombosis, which is the actual forming of a clot.
And we know you're digging into this for your own reasons. Could be work, could be just personal curiosity about how this complex system works. Whatever the reason, our mission here is to sift through what you've shared, pull out the core insights, make it understandable, maybe even find a few surprises, and give you a really solid grasp of what matters.
Right. So maybe we should start with the basics, the fundamentals of hypercoagulability itself.
Good idea.
Like we said, it's that push and pull, procoagulants versus anticoagulants. Your sources lay out about 4 main ways this balance gets tipped off kilter.
Okay, 4 pathways. Let's unpack those. What are they?
So the first one involves your platelets. They can become overly active. We call it hyperaggregability. Platelets are like tiny first responders for vessel damage.
Okay.
If they get too jumpy, too eager, they can start clumping together, even when there isn't really a significant injury. Inflammation can really ramp this up.
Makes sense. Like an overzealous repair crew.
Exactly. And the second way is having increased amounts or maybe just increased activity of the actual clotting factors. These are more like the building blocks for the clot structure.
Right.
So if you have too many materials delivered to the site or the workers are, supercharged, the structure goes up too fast, too easily.
That analogy works well. Too many eager workers, too many building supplies. What about the other 2 ways?
Well, the third way is when your body's natural anticoagulants, the built-in brakes, aren't working as well as they should.
The stop signals we mentioned.
Precisely. Things like antithrombin the third, AT3, and protein C, they're crucial checks on the system. If you don't have enough of them, maybe genetically, or they're just not functioning right, the clotting process doesn't get slowed down properly.
Okay, ineffective brakes. And the last one?
The fourth way is a problem with fibrinolysis. That's your body's system for breaking down clots after they've done their job.
So clot removal.
Yeah. Even a necessary clot isn't meant to stay forever. If that cleanup system is faulty, clots can hang around longer than they should and cause trouble.
So it's not just one potential issue, but kind of a few different angles. Now, the material also talks a lot about Virchow's Triad. That sounds pretty central.
Oh, it absolutely is. Virchow's Triad is really fundamental to understanding why clots form. It outlines the 3 main categories of factors that contribute.
Like a 3-legged stool.
That's a great way to put it. If any of those legs gets wobbly, the risk of a clot goes up. It's a really helpful framework.
Okay, let's hear about the 3 legs then.
The first leg is endothelial injury. That's damage to the inner lining of your blood vessels.
Okay, the vessel wall itself.
Exactly. Damage there can expose stuff underneath that basically kicks off the whole clotting cascade. And interestingly, this is the only one of the 3 that's really thought to be capable of causing a clot all by itself.
Wow, that really highlights how important healthy vessel walls are. What are the other 2 legs of the stool?
The second is altered blood flow. This can mean blood flow that's too slow, stagnant, we call that stasis, or flow that's turbulent, not smooth.
Like in certain heart conditions or just from being immobile?
Exactly. When blood isn't moving properly, clotting factors can kind of hang around, concentrate, and interact more easily. That's partly why we encourage people to move around after surgery,
Yeah.
to prevent that stasis.
Right, keep things flowing. And the 3rd leg?
The third leg is hypercoagulability itself, the very thing we started talking about, that underlying tendency towards clotting due to the imbalance of pro and anticoagulants.
So the triad includes the state we defined earlier.
Precisely. And you can easily see how these 3 often work together, right?
Yeah.
Someone might have an underlying hypercoagulable state, then maybe they're bedridden after surgery, causing blood stasis.
And maybe there's some minor vessel irritation from an IV catheter.
Exactly. That combination dramatically increases the risk. It's often a mix of these factors.
That makes it much clearer how these things converge. Now, location. Where do these clots actually tend to cause problems? Your sources listed some common spots?
Yes, they did. Some frequent locations include the pulmonary arteries, Those are the big vessels taking blood from the heart to the lungs.
A PTE, pulmonary thromboembolism.
Right. Another common area is the distal aorta, the lower part of the main artery leaving the heart, often affecting the back legs.
Okay.
Clots can also form in major veins like the cranial vena cava, returning blood from the upper body, or in the vessels supplying the intestines and the mesenteric vessels, or even the portal vein going to the liver.
So really critical areas, which underscores how serious this can be.
Oh,
Now, you mentioned hypercoagulability itself usually doesn't cause symptoms.
that's right.
So how do you know when it's actually led to a thrombus, to a clot forming?
That's the key point.
Yeah.
You don't feel the tendency, you feel the consequence. The signs only appear once a clot has formed. And as your material is really stressed, what those signs are depends entirely on where that clot has ended up.
Location, 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 as they say.
Pretty much.
So give us some examples. What signs point to a clot in, say, the lungs?
Okay, so for a pulmonary thromboembolism, a PTE, the signs can be really dramatic and sudden. Acute, severe shortness of breath, that's dyspnea and really rapid breathing, tachypnea. Or sometimes it's more chronic, just sort of persistent labored breathing that develops over time.
And what if the clot is arterial, maybe blocking blood flow to a limb? An AE?
Right, an arterial thromboembolism, especially a distal one affecting the limbs, often presents as sudden weakness or even paralysis, paresis, or paralysis in that limb. Pain is common too.
And how would you differentiate that?
A really key sign for distal AE is feeling the pulses. You'd find a weak or totally absent femoral pulse in the affected leg, and the limb itself might feel noticeably cold compared to the others.
Ah, okay.
And there's an interesting difference noted in the material between dogs and cats here. In dogs, the onset might be a bit more gradual, whereas in cats, it's often described as very, very acute, like fine 1 minute, paralyzed the next.
That's a crucial distinction for owners and vets. What about other scenarios like DIC? You mentioned that earlier.
Yes, disseminated intravascular coagulation, or DIC. That's a whole different beast, really. It's this widespread activation of clotting throughout the tiny blood vessels.
So lots of small clots everywhere.
Initially, yes. But what's really characteristic and kind of paradoxical about DIC is that this initial clotting frenzy often uses up all the clotting factors and platelets. So it's frequently followed by a phase of severe bleeding.
Wow. From clotting to bleeding, that sounds incredibly dangerous.
It is very complex and very serious.
Okay, so we've covered the what, the where, and the how it looks. What about the why? What underlying conditions or risk factors actually predispose someone to this hypercoagulable state?
Well, as we talked about with Virchow's Triad, thrombosis is usually tied to conditions that bring one or more of those elements into play: vessel injury, altered flow, or that inherent hypercoagulability.
Right.
And your sources provided a pretty comprehensive list of associated conditions.
Let's go through some of the main ones. What kind of diseases put patients at higher risk?
Okay, well, a big one is immune-mediated hemolytic anemia, IMHA. That's where the immune system attacks red blood cells.
We hear about that one causing clots.
Definitely. We already mentioned DIC, which is both a cause and effect in some ways. Then there are conditions where the body loses protein, either through the kidneys protein-losing nephropathy, or PLN, or through the gut protein-losing enteropathy, PLE. Losing proteins like antithrombin contributes.
Ah, losing the natural brakes.
Exactly. Endocrine diseases like hyperadrenocorticism, Cushing's disease, or even just being on corticosteroid therapy can increase risk.
Steroids too, interesting.
Yes. Neoplasia cancer is a major risk factor. Widespread inflammation, maybe from something like parvovirus or severe pancreatitis. Sepsis, which is a massive systemic infection. And various types of heart disease can also contribute, often through altered blood flow.
That's quite a list. It really shows how hypercoagulability often isn't the primary problem, but a dangerous complication of something else.
Very true.
So when a patient comes in showing signs that could be a clot, like breathing trouble or limb paralysis, what else needs to be considered? What's the differential diagnosis process like?
Differential diagnosis is critical. You have to rule out other things that look similar. For instance, if you suspect a PTE because of breathing difficulty,
Yeah.
you also need to think about bacterial or fungal pneumonia, maybe fluid in the lungs from heart failure, pulmonary edema, or even heartworm disease, depending on the area. They can all cause respiratory distress.
Right, you can't just jump to PTE.
No. And for that distal AE, the limb weakness or paralysis, you need to consider other neurological or orthopedic causes. But as we mentioned, those specific findings, the absent femoral pulses, the cold limb, Those really strongly point towards ADE.
So those clinical signs are really key differentiators. What role do lab tests play in figuring this out?
Lab tests are very important. Your routine blood work, CBC, chemistry panel, and urinalysis can often give clues about an underlying disease like the IMHA or kidney disease we mentioned. Or they might show organ damage resulting from the clot.
Okay, so general health picture. What about tests more specific to clotting?
Yes, there are more specific ones. One that's used a lot is the D-dimer test.
D-dimer, what does that tell us?
D-dimers are fragments produced when a clot is broken down by the body's fibrinolysis system. So a high D-dimer level is very sensitive for detecting that clot breakdown has been happening recently.
Sensitive meaning?
Meaning if there hasn't been significant clotting and breakdown, the D-dimer level is likely to be normal. So a normal D-dimer can be quite useful to help rule out a major thromboembolic event.
Okay, good for ruling out. But if it's high?
If it's high, it tells you there's been fibrinolysis, but it doesn't tell you where the clot was or why it formed. Many things can raise D-dimer levels.
Got it. What else?
Measuring antithrombin, AT levels, can be helpful. Remember, that's a natural anticoagulant. If levels are low, the sources mention around 60–75% of normal, that indicates an increased risk for thrombosis.
Okay. And what about standard clotting times, like PT and APTT?
Interestingly, your sources point out that shortened PT or APT times are actually not reliable indicators of a hypercoagulable state.
You'd think faster clotting in a test tube means more clotting in the body.
Yeah, it seems intuitive, but it doesn't really work out that way clinically for predicting risk. Longer times indicate problems with clotting, sure, but shorter times aren't diagnostic for hypercoagulability.
Good to know. Any other more advanced tests?
Yes, there's Thromboelastography, or TEG. It's a more complex test that looks at the whole dynamic process of clot formation and break down its physical properties over time.
A more global picture of clotting.
Exactly. It can help identify hypercoagulable states and conditions like DIC, Parvo, IMHA, PLN, giving a fuller picture than just snapshot tests. And one more thing, if a PTE is suspected, checking arterial blood gases often reveals low oxygen levels, hypoxemia.
Okay, so labs give us biochemical clues and risk assessment. What about actually seeing the problem, imaging?
Imaging is absolutely crucial for actually locating clots or assessing their impact. Chest x-rays, thoracic radiographs are usually a first step for suspected PTE.
Makes sense.
But, and this is surprising to many, the chest x-rays can often look completely normal or have only subtle changes, even when the patient is in severe respiratory distress from a PTE.
Really? Normal x-rays with breathing problems?
It happens quite often, so a normal chest x-ray doesn't rule out a PTE.
Okay, that's important. What about ultrasound?
Abdominal ultrasound is very useful for looking for clots in the distal aorta, which is a common cause of ATE in the hind limbs. You can often directly visualize the blockage.
And echocardiography, heart ultrasound.
Yes, echo is key for a couple of things. It can sometimes identify clots within the heart chambers themselves, and it's vital for assessing pulmonary hypertension, high blood pressure in the lung arteries, which can be a consequence of PTE.
What signs on the echo suggest pulmonary hypertension?
You'd look for things like enlargement of the right side of the heart, the right ventricle might be dilated or thickened, the main pulmonary artery might look bigger than normal, and there might be leakage back through the tricuspid valve called tricuspid regurgitation.
So lots of specific clues from echo. Are there even more direct ways to visualize clots and vessels?
Yes, though they tend to be more specialized or invasive. Angiography is one.
Injecting dye.
Right. You inject contrast dye into the blood vessels and take x-rays. It gives a very detailed map of blood flow and can pinpoint exactly where a clot is located and how severe the blockage is.
Okay.
There's also nuclear perfusion scintigraphy. It's non-invasive, uses a radioactive tracer to see how well blood is flowing to the lung tissue. Abnormal patterns can support a PTE diagnosis.
All right, so a whole range of diagnostic tools. Once a clot is suspected or confirmed, what happens immediately? What are the first steps in treatment?
Usually the patient needs to be hospitalized. Inpatient care is pretty standard to start managing the clot and get anticoagulant therapy going right away.
And besides the specific clot treatment?
Supportive care is vital. Things like making sure the patient stays well hydrated, maintaining good blood flow or perfusion to all tissues, minimizing anything that could cause more blood stasis.
Like stripped rest.
Absolutely critical. Severely restricted activity. Also, careful monitoring and correction of any electrolyte or acid-based problems. And being very careful with IV catheters, as they can be sites of vessel irritation.
Makes sense. What about specific symptoms?
For PTE patients, oxygen therapy is often essential to help with breathing. And for acute pain, like with an ATE, good pain management with analgesics is really important.
Okay.
And one crucial thing is talking to the owners. It's really important to explain the risk of future clots, especially if the underlying condition that caused the first one is still present.
Managing expectations and planning ahead, that's huge. So let's get into the medications. Anticoagulants first. What are the main buyers?
The most common initial go-to is often unfractionated heparin, usually given as injections under the skin multiple times a day.
Dosing, monitoring.
Your sources give typical starting doses, something like 150, 200 units per kilogram every 6 hours for dogs, maybe 200 units per kilogram every 8 hours for cats. But the key is monitoring the APTT.
That clotting time test.
Right. You check it daily, usually about 2 hours after giving the heparin, and you adjust the dose up or down to keep the APTT in a target range, typically about 1.5 to 2 times the patient's normal baseline value.
Okay, requires careful adjustment. Any alternatives to standard heparin?
Yes, there are low molecular weight heparins, LMWHs like enoxaparin or dalteparin. They're generally considered a bit safer, maybe less risk of bleeding, but they are more expensive.
How are they monitored?
Usually not with APTT. Monitoring often involves measuring something called anti-factor Zadze activity, which is the more specialized test. A typical starting dose for enoxaparin might be around 1 milligram per kilogram subcutaneously every 12 hours.
So heparin variations for initial treatment. What about longer-term anticoagulation?
That's often where warfarin comes in. It's an oral medication taken usually once a day. It works differently by interfering with vitamin K, which needed to make some clotting factors.
How is warfarin dosed and monitored?
Starting doses are usually quite low, maybe 0.1 to 0.2 milligrams per kilogram once daily. The monitoring relies on the PT, prothrombin time. You adjust the dose aiming to prolong the PT to about twice the normal baseline.
So heparin usually first, maybe LMWH, then potentially transitioning to warfarin for long-term oral therapy. What about drugs that target the platelets, not the clotting factors?
Right, the antiplatelet drugs. They have a role too, often for prevention, either initial prevention in high-risk cases or preventing a recurrence after a clot. Aspirin's a classic example.
Aspirin doses.
The dog dose can vary quite a bit, from 0.5 up to 5 milligrams per kilogram, maybe every 12 or 24 hours. For cats, it's used much more cautiously due to their metabolism. A common dose is just 5 milligrams per cat, maybe only every 72 hours.
Big difference there. Any other major antiplatelet drugs?
Yes, clopidogrel is very important, especially in cats. It's also used for prevention or preventing recurrence. Doses mentioned are around 1 milligram per kilogram daily in dogs, and for cats, often 18.75 milligrams per cat daily, which usually means cutting a standard 75 milligram tablet into quarters.
And why is it especially important in cats?
Because studies have shown that clopidogrel is actually more effective than aspirin at preventing recurrent aortic thromboembolism, that common devastating hind limb clot in cats. That's a really key practical point.
That is a key point. Okay, so we have anticoagulants targeting factors, antiplatelets targeting platelets. What about drugs designed to actually bust up existing clots? Thrombolytics.
Yes, thrombolytic drugs, the clot busters. Drugs like streptokinase and urokinase fall into this category. They work by activating the body's own clot-dissolving system.
That's powerful.
They are, but, and this is a huge but, they come with significant risks. Serious side effects are a major concern.
Like what?
The biggest worry, especially highlighted in your sources for cats with ADE, is reperfusion injury. When you suddenly restore blood flow to tissue that's been starved of oxygen, it can cause a massive inflammatory reaction and release of toxins that can actually be fatal.
Wow. So they're used very cautiously.
Extremely cautiously. Generally reserved for life-threatening clots, where restoring blood flow is absolutely critical and maybe outweighs the risks. Think clots in the brain, or major clots cutting off blood supply to the intestines or kidneys.
And the protocols are specific?
Very specific. Usually an initial loading dose given intravenously, followed by a continuous infusion over several hours. Your materials listed example protocols, like for streptokinase, maybe 90,000 units IV over an hour, then 45,000 units per hour infusion. Urokinase, maybe 4,400 units per kilogram bolus, then the same dose per hour infusion. But again, this is specialized high-risk therapy.
That potential for severe side effects really underscores the caution needed. Are there other general precautions or interactions to be aware of when using any of these anticoagulant or antiplatelet drugs?
Absolutely. Several important points. One is about starting warfarin. You generally don't want to start it alone
Why not?
because it initially depletes some natural anticoagulants, like protein C, faster than some clotting factors. So there can actually be a brief period right at the start where the blood might be more prone to clotting. That's why you typically overlap warfarin with heparin for the first 4 days or so, until the warfarin fully kicks in and the PT is therapeutic.
Okay, crucial overlap period. What else?
Warfarin is notorious for interacting with lots of other medications, so it's absolutely vital to recheck the PT monitoring whenever any other drug is started, stopped, or the dose is changed.
Good point. And the biggest overall risk?
Bleeding. That's the major complication with any anticoagulation. You have to watch closely for any signs of bruising, nosebleeds, blood in urine or stool, or more serious internal bleeding.
And if bleeding does happen?
First step is stopping the anticoagulant drug. Then, depending on which drug it is and how severe the bleeding is, you might need specific antidotes. Protamine sulfate can reverse heparin, and vitamin K is the antidote for warfarin. Sometimes plasma transfusions are needed too to supply fresh clotting factors.
So, managing the risk is as important as the treatment itself. Finally, what about long-term follow-up? How is therapy monitored once the patient is stable or goes home?
Monitoring is key, especially for warfarin. Initially after starting, the PT is usually checked daily for maybe 4 or 5 days, about 8 hours after the daily dose.
Okay.
Once the target PT range is stable, you usually stop the heparin. It's often wise to recheck the PT about 6 to 8 hours after that last heparin dose, just make sure it stays in range.
And after discharge?
The frequency of PT checks gradually decreases, maybe twice a week initially, then weekly for a few weeks, then maybe every month or two, assuming everything stays stable. But any changes in health or medication would warrant more frequent checks.
This has been incredibly comprehensive. You've really managed to break down a very complex topic, hypercoagulability, thrombosis, into much more digestible pieces.
Well, the goal was to clarify the core concepts from your material. The main takeaway is that hypercoagulability is this complex state, an imbalance, often driven by underlying diseases.
Right, involving Virchow's Triad vessel health, blood flow, and the clotting balance itself.
Exactly. And that predisposition can then lead to clots, with signs that really depend on where that clot lodges.
And we've covered the diagnostic journey, the clinical signs, the lab tests, from basic to specialized like D-dimer and TEG, the imaging like ultrasound and echo.
And the treatment options? From supportive care and initial heparin or LMWH to long-term warfarin or antiplatelets like clopidogrel, and the very cautious use of thrombolytics.
Understanding all those interconnected pieces is just so vital, whether you're dealing with this professionally or personally.
Absolutely.
So maybe a final thought for you, the listener, to chew on. Given this wide range of underlying conditions that can trigger hypercoagulability, everything from immune diseases to cancer to inflammation, what potential role might things like proactive screening or maybe even broader lifestyle factors play in identifying individuals at higher risk before a clot ever forms? It really makes you think about the deep interconnectedness of all our body systems, doesn't it?